All right, Eddie, you can go ahead.
Okay. Good morning and welcome. Good morning, good evening, or whatever. Welcome, everyone. My name is Edgardo Reich, and joining Professor Raimundo Mateos, we will try to moderate the today debate. We have now a very important and sometimes controversial topic. The title of the today debate is Medical Assistance in Dying, regarding especially neuropsychiatric diseases and dementia. For such discussion, we account today with a luxury panel of experts from different origins, from different countries, and I suppose also, of course, with different opinions. The format of the debate is the usual one. We will introduce each of one of the speakers, and at the end of these talks, approximately 45 minutes, we will start the debate opening to the audience and opening to all questions that arises from the audience. Thank you very much for your presence. Raimundo?
Yes. Hello, everybody. My name is Raimundo Mateos, Professor of Psychiatry at the University of Santiago de Compostela. Let me thank you all of you for your attendance to this important meeting with this important topic. And let me remind you some characteristics of our organization. We celebrate and we have this kind of varied activities. And the International Psychogeriatric Association mission is to promote better mental health for all the people. The association has a long trajectory of more than 30 years and has members of all around the world. It's a very interdisciplinary association. IPA represents a commitment to serving the broad spectrum of issues, perspectives, opportunities, and challenges of geriatric mental health around the world. Next. And we cordially invite all of you to attend the GR Congress that this year will take place in the historical city of Kanazawa, Japan, from 25-27 September. And you can follow the social media to prepare this very exciting Congress.
Okay.
I think, Eddie, you can continue.
Okay, thank you. We would like to introduce our first speaker. Our first speaker is Professor Carla Kotze from South Africa. Carla is head of geriatric psychiatry at West Coast Hospital. She is also the president of the College of Medicine of South Africa Council of Psychiatrists, and she completed a master in applied ethics, focusing on ethical complexities of medical assistance in dying for people with serious mental illnesses. Carla, please, the stage is yours.
Thank you very much. I'm just going to quickly share my slides here. Okay, is everything in order? Can you see and can you hear me clearly? All right, thanks. Thank you very much for this opportunity. I think, as already has been said, this is such an important and developing topic. So it is really a great privilege to be part of this discussion, and I'm really looking forward to hearing the opinions from other people. I think we can all agree that the idea of helping people to die as healthcare professionals is really one of the ethically most challenging and contentious issues. There's really a lot of debate about it. And for me, it is really becoming even more and more difficult as there are now more countries permitting medically assisted dying for patients in the absence of a terminal condition when they only have a psychiatric diagnosis, like PTSD, schizophrenia, or depression, for example. So this is really an area that for me is even more challenging to wrap my head around than when there's a terminal condition present in these patients. So just a little bit, just a summary of some of the definitions is obviously if it's end of life assisted in dying, that is really more available in some of the more privileged countries. We don't have anything like that in South Africa. And this is then usually in conditions where the patient might want to live, but then they don't have a very long prognosis. It is a condition that will mostly, they say, within 6 months, they are likely to then reach the end of their life. But they then access these options because they want to have control, and it's about the dignified death. Where in contrast, where it is a psychiatric assistance in dying, this is then a case where it's people who only have a serious mental illness. They don't have anything that is life-threatening. We know that with mental illness, it's usually only the eating disorders and if there's obviously suicide, but it's not the condition itself that will kill a person. So this is then why this is such a very vulnerable population that requires additional protections, where we then come in. So just a little bit more about the South African situation. So our laws around this is really very outdated. There's been this draft regulations or legislation since 1998 that has not been finalized. So there's been a few case studies and in the courts where people did keep permission, but those were really controversial scenarios. So we really don't have anything specifically to guide us in our country. And even something as simple as a living will, we need better legislation to protect doctors if they do then withdraw treatment or administer something to assist a patient, because at the moment it's really hanging around. And to then make it even more complex is in our very diverse cultural setting, a very big proportion, people who believe more in the Black traditional type of religions, they don't really consider this an appropriate topic to discuss. They mostly believe, or a lot of them still believe in ancestors and that they will become an ancestor when they die. But then if they want to achieve that, they can't go for assistance in dying. Suicide is frowned upon. And it is really not a topic that people are very open about. So whenever I have these discussions with people, it is really the first time in many scenarios where they even hear about things like advanced care planning and living wills and so on. So that is quite challenging, and especially then to educate them to a sufficient degree that they can make an informed decision about these things. So the problem that we have specifically now, I'm not going to focus really on the dementias. I think that's for me a different thing, where the trajectory of the illness is a bit different. But we know that with our serious mental illnesses, bipolar patients with bipolar and those types of conditions, they sometimes make bad decisions, about if they should comply with their treatment. And there's obviously the idea of suicide ideation that's frequent in these conditions. So when is it a suicidal idea, or when is it that they're making a rational decision that they just don't want to live anymore? So that makes these scenarios in terms of their decision-making capacity very difficult. Now, we know that people with these serious mental illnesses can make many decisions, because it has to be very specific for what they are deciding about. But as you can imagine, the risk in these types of scenarios is extremely high. So the threshold for the capacity will have to be very carefully assessed to make sure that this is not just something that is driven by the illness, where it is just actually a suicidal ideation that needs further treatment, and that we can't allow them to follow this route. So it's really a moral dilemma, and I think a lot of people have this concern here. I'm going to have two slides where I'm going to summarize some of the arguments, but I think we all know that if you have a good philosopher, there's always going to be people who's going to be able to argue very convincingly on either side. So it is not like there is a black and white. There's many gray areas in this debate, especially where we are uncertain about somebody's decision-making capacity, because it's a normative concept, and depending on where you are practicing, the background that you're from, you can have very different viewpoints, and it's really driven by the society that we are based in. So yes, the first slide that really just summarizes very briefly some of the main arguments. Now, like I said, a lot of these arguments can be used on both sides. But for me, the one very convincing argument in support of medically assisted dying for serious mental illness is the idea of the unbearable suffering that these patients do experience. I think we tend to think that it is really only when you have physical pain or something like a cancer diagnosis or a terminal neurological condition that people suffer. But I think a lot of the experts and people that might be in the call today have an experience and a background where you deal with people with mental health issues, and that suffering is just as tangible and real as physical pain. So we cannot dismiss that, and that is where we must really see how we can help them. So I'm not saying that medical assisted dying is the answer for them, but it is just something to consider, that if you feel that it is acceptable for a terminal condition, how do you justify that for a serious mental illness you think it is not a dignified way of dying? But then against these are obviously the safeguarding of life and preventing suicide. Once again, as a mental health care practitioner, that is what I was trained in. If somebody is suicidal and they don't want to live, how can you help them? How can you instill hope? How can you get them to feel better and help them to live a life that is worth living? And the other concern in a country like ours in South Africa, we're not a very rich country, political instability, high unemployment rates, and I'm going to talk a little bit more about that in the next few slides, is the external pressures and circumstances from family, societies, healthcare limitations, and all those types of things that impacts these decisions. So the external contributing factors, I think, is gaining much more importance if you look at the whole externalism movement. Now, this is not saying that your brain is not important, but it really focuses on how your brain influences or interacts with your body, your hormones, your neurotransmitters, and then with your external environment. Your nutrition is so important, where you are staying. If you have security at home, if you feel threatened the whole time, all those external factors contribute to mental illness and to how you make decisions. And if you feel that there's really no hope in your environment, it can then contribute to these types of requests, which makes it very difficult. I think just with the whole RDoC environment, also there's a very big focus on the environment to address these systemic inequalities and the social environment and how that contributes to distress. And I think we all, even if you don't watch the news, we're all aware of the instabilities in specific countries, and bombings and wars and forced migration and epidemics. We had the COVID recently. All these things causes a lot of distress in people. And we must just ensure that medically assisted dying is not then in the end an escape from these social difficulties, and that there is really an indication for it if we want to follow that route. And that is really the big challenge, I think. And this slide is just to then really focus on, how we must implement palliative care, advanced care planning, address all these different systems. And that is why you can never deal with these things as an individual practitioner. It must be a multidisciplinary team where there must be more than one assessment. You must really look at the decision-making capacity in different scenarios at different times, try and optimize it with having interpreters, people who's sensitive to the culture of that individual. So there's so many things that we have to consider when we are involved with these types of assessments, that I think it is very time consuming and not easy to implement in countries where there's resource restraints. So I think this is, I'm getting to the end. Hopefully I won't be over time, but it's really that we must ensure access to care, and that we must ensure that in our care facilities, our psychiatric hospitals, that there's access to palliative options as well. That it's not just that a patient can't make a decision because they're in a psychiatric hospital, so we're giving antibiotics or we're putting in a peg tube, doesn't matter what they want. We must still have these discussions with them at times where their capacity is more stable, and we must implement palliative care options even for patients where there's no terminal condition, where it's just really a treatment-resistant serious mental illness. That is also something, the principles where we can then just focus on the quality of life of those individuals. And we must really balance the principles. You know, there's always going to be the deontological versus the utilitarians, where there's different focuses in the ethical arguments. We must keep all that in mind, and that is where the team also then comes in again, where you can have different views to consider what will be in the best interest of the person that you are dealing with. And this is then at the end where I'm coming now. I think this is where we are here today as well as members of the IPA, where we have a very important role to educate people, to make them aware of the options that are available, so that they can make informed decisions before it gets too late. You know, when you are too ill and you can't make decisions anymore, then it is a big burden on the family. And we must really try to get those things in place to assist families in those difficult scenarios. Then I just really want to alert people to the Congress again. That was just one of the slides that we were asked to share. I think it is going to be great, and hope to see you there. My conclusion then here is I have these two questions that I have been grappling with that I don't have the answer to. So I want to pose these questions to the other speakers and to the audience. And I would really like to hear if people feel that it is possible for an individual who's been diagnosed with a serious mental illness to be well enough, you know, they're stable enough that they can make an informed decision, that their capacity is not impaired, but that mental illness is at the same time still sufficiently serious enough that this qualifies them for assisted dying. That balance for me, I can't get my head around that. And like I say, I really don't know where the answer is there. And the other one is that, is it ever appropriate to consider psychiatric medical assistance in dying? And when will that be appropriate if there is no other life-threatening condition? Thank you very much.
Thank you very much, Carla. And now it's time for the next speaker. It's my pleasure to introduce Dr. Gina. She is an assistant professor and geriatric psychiatrist at the University of Toronto. Her PhD was on novel therapeutics in Alzheimer's disease, and her clinical interest is in complex cases in dementia. She has been involved in numerous complex medical assistance and dying cases. Dr. The floor is yours.
Thank you so much. And it's truly an honor to be here today. And I was just looking at everyone's introductions from where they're from, and it's truly a global audience. I'm just going to share my slides. This is probably not. All right. All right, here we go. So today I'd like to talk to you about the changing landscape of medical assistance in dying in Canada as it pertains to dementia. And it's a rapidly changing field. So even just 6 months ago when I was presenting on this topic, things have changed and shifted. Just as a preamble, I'm not an assessor or a provider of medical assistance in dying, but as per my introduction, I have been involved in quite complex cases where a specific question was posed to me as to whether or not the individual requesting MAID who had concomitant brain conditions, whether it was cognitive or psychiatric, whether or not those symptoms of their brain condition was getting in the way of making a capable wish. And since then, my interest in this topic has grown. And to be honest with you, in my institution, there's been quite a bit of conflict and almost interpersonal rifts within my department around this topic, to the point where there's almost been an avoidance of this topic. And I think it's important for us to continue the discussion. So I'm so glad to be able to do that with you today. And I'm also mindful of the fact that I'm living in Canada, practicing in this wonderful country, and that there have been many people living here for thousands of years before me. So I always try to make sure whenever I give an academic presentation to learn a couple of things around the indigenous people who've lived in this land. So here I'm just sharing a quote that I was reading up last night. And I want to talk about how MAID for dementia patients is being delivered in most of Canada right now, and then how it's been shifting with the province of Quebec now having introduced advance requests for MAID in dementia. So MAID became legal in Canada in 2017. It was an exemption from the criminal code, which has since been modified about 4 years ago to introduce 2 tracks for medical assistance in dying. Track 1, as it's colloquially called, is for an incurable illness where natural death is reasonably foreseeable. So it's an incurable illness where the disease is expected to continue to progress. Track 2 is for incurable chronic illnesses where a natural death is not reasonably foreseeable. So if you were to ask me which track dementia qualifies under, it could be seen under both, but I'll show you some of the data that has come out. This on the right is one of the first patients living with dementia that died of MAID in Canada. And the provider is now the president of the Canadian Association of MAID Assessors and Providers, so CAMA. So currently it's estimated that about 700,000 individuals live with dementia in Canada. And if we were to think about how many individuals are actually receiving MAID for their dementia diagnosis, it's actually currently an exceedingly low number of individuals. So I don't have the most recent report from 2024. It hasn't been published yet. But in 2023, about 100 individuals received medical assistance in dying where their main diagnosis was listed as dementia. And a couple of slides ago, I asked whether or not it was under track 1 and track 2. And in my province, in Ontario, 99% of individuals who applied for MAID for where the diagnosis was dementia was under track 1. So where natural death was reasonably foreseeable. And again, this is an exceeding small percentage of individuals living with dementia in Canada. This is what the form looks like if you were to apply in Ontario, something that you can download on your own. And I just want to focus on how dementia patients were to apply to this and how they would qualify for medical assistance in dying. So you have to be over the age of 18. You have to have a serious incurable condition. And you also have to have noticed a decline in your capability from your previous baseline. And you have to be experiencing suffering. And that definition of suffering is very individualized. It has to be your own personal suffering, whether it's physical or psychological suffering. So currently, medical assistance in dying for dementia patients in Canada borrows from the practice from the Netherlands. And I saw that in the audience today, there are some of my colleagues from the Netherlands here. Welcome. We have learned for their decades of experience providing MAID in dementia patients. The approach is called 10 minutes to midnight. And it's the idea of dementia. Their cognitive capacity to consent continues to decline over the years. They may still enjoy good quality of life, but there's the fear that they're going to imminently lose the capacity consent for MAID. So that when they're requesting for medical assistance in dying, that the assessor periodically check in on the patient. And when there's this feeling that they're about to lose capacity, that's when they provide the medical assistance in dying procedure. The downfall of that, unfortunately, is that there may still be good quality of life as it is acceptable to the individual left, that, that their fear of losing capacity imminently makes them receive MAID too early. The other fear is that by the time the assessor comes to see you, you've already hit midnight, aka you've already lost capacity to consent. So that also, from a resource perspective, requires quite a bit of follow-up from the MAID providers and the assessors. And that speaks to clinician availability. And I also want to talk about anticipatory suffering. So I've talked to you about the challenge of the progressive loss of cognitive capacity as per the definition of the disease of dementia. And then there's the idea of anticipatory suffering. I, in my early stage of the illness, might be suffering from the idea of what I might look like in the future. So as a geriatric psychiatrist, seeing these patients on a daily basis, I can think of some ideas of what that personal suffering might look like. So for example, paranoia, we see that as a psychiatric symptoms of dementia. Sundowning, that, sort of in the afternoon, your cognitive reserve has been depleted and you're just irritable, sometimes aggressive, that there's a reactivation of prior mental illnesses or traumas. I see this a lot when I was training in a hospital or a long-term care facility where there were a lot of survivors of the war, being in restraints frequently or having pain but being unable to vocalize this. These are all examples of personal suffering that might happen in the future when your dementia progresses. But we, as geriatric psychiatrists or dementia specialists, are unable to predict who will go on to develop these symptoms. So there's an uncertainty around that. Also, there may be a loss of personal dignity, right? The loss of independence, that you're dependent on other people providing a lot of personal care on your body, or having some of these psychiatric symptoms which are, distressing to you, saying racial slurs to PSWs, personal support workers, or inappropriate sexual behaviors, which we also see in some cases, but not all cases, of moderate to severe stages of dementia. Or the idea of losing your personhood, or you used to be someone who was a family person and you no longer quite are able to recognize your family members. Or you went from a very dignified person to someone who's highly irritable. And of course, there's the idea of being an undue burden on your family members. And, in Canada, we take great pride in having a public healthcare system. And yet, when we look at the cost of dementia care, quite a bit of cost is incurred on the families or on the individual living with dementia. So this is not like an overestimation. In fact, it's quite conservative. When you look at the cost of private care of an individual with moderate to severe stages of dementia, if they were to remain at home, the cost out of your own pocket would be about 20,000 Canadian dollars a month. Now, our currency is very weak, but it's still a lot of money, I assure you. Or you enter long-term care facilities where there's years of wait lists. And even there, if you have a shared room, there's quite a bit of cost that is incurred on the family or yourself. So, currently, dementia patients receive medical assistance in dying early on in their disease because of that 10-minute to midnight approach. When they might want to receive MAID might be when their disease has progressed a little bit further, when they're no longer able to have a competent wish for that, when they're a little bit more dependent, or where their psychiatric symptoms are more severe. So that is called an advance request for medical assistance in dying. And it would be almost like an advance directive, which is available in some provinces in Canada, but it would have to be after they've already been diagnosed and the individual lies out with great specific detail if those certain conditions are met, and only if, then they would like to receive medical assistance in dying after they've already lost capacity to consent. So there was a nationwide survey out in 2020, right before the pandemic hit, of whether or not Canadians support this idea of an advance request for medical assistance in dying. And they use Alzheimer's disease as a specific example. And I have to tell you, it broke the computer. Never before had so many people submitted a response. And 2020 was before artificial intelligence was even a thing, but they had to use some sort of an algorithm, computer algorithm to compute the responses just because it overwhelmed the server. And there was an enormous support for the idea of advance requests for medical assistance in dementia, particularly for dementia. Now, I also wanted to highlight that when it comes to this topic of medical assistance in dying, as my colleague has said, it brings out so many opinions to the point where it almost drowns out the wish of the patient. And so I tried to look at all the different sort of stakeholders or perceived stakeholders or self-appointed stakeholders. And I wanted to look at what is the voice of the patient that is living with dementia. So I looked at the Alzheimer's Society in Canada, and even they support the idea of an advance request for MAID when it comes to dementia. And more recently, about 7 months ago, advance requests for medical assistance in dying, in particular in dementia, is now legal in one of the provinces in Canada. And this might come as a surprise to even some of us practicing in Canada, because it does clash with the current laws. But there's been quite a bit of vocal support for this to continue to occur in the province of Quebec. And in 2027, there is an opportunity for the laws to be revisited and nationwide, and advance requests for MAID in dementia may become legal everywhere else. So currently, the rest of us, not in Quebec, are kind of watching what's happening in that province. Just in the interest of time, I'm just going to go over the form that actually, I don't think I'm supposed to have this form, but it is available in French. I translated it into English. This is a form that is only provided by trained MAID assessors and providers in Quebec. They have the form. If you want to make an advance request for medical assistance in dying, you provide this form to the individual. And in the first couple of parts, you talk about your own diagnosis, the conditions that, if they're ever met as a result of the disease, when you would like to receive medical assistance in dying. And the last part is by the physician to confirm that you've given adequate psychoeducation around the illness and that you agree that this hypothetical scenario, those hypothetical conditions, are a direct result of the illness. Now, what is very interesting about this legislation in Quebec is that, in contrast to everywhere else in Canada, where the definition of suffering is personal to the individual making the request, when you read the legislation in Quebec, I had to put this through an English translator because most of it is in French. It highlights that at the time of the advance request being activated, so someone in the family or a healthcare provider feels that the conditions of the advance request might be met now at this point where the individual no longer has capacity, but they're meeting some of those conditions. When the assessor comes to look at the patient has to be convincing to the assessor that there is indeed personal suffering. And that is different from what the language was before. And so this is the first time where the assessor has to be convinced of suffering. In the interest of time, I'm just going to skip over a couple of slides, but I do want to highlight here that MAID providers will likely receive or experience a great deal of moral distress. Because imagine, all of us in geriatric psychiatry can imagine that, we all know of these dementia patients who are pleasantly confused. They're singing to themselves, they're smiling, they're oblivious. And if that individual, a couple of years ago, 10 years ago, 5 years ago, has an advance request for MAID, and they technically meet those conditions, they're dependent on care, but they appear pleasant, there's going to be quite a bit of moral distress on the assessor if they're not convinced that there indeed is personal suffering. So there are some guidelines that have been published. Just in the interest of time, I probably have to skip through them. But there is this idea of a disability paradox, that the idea of anticipatory suffering, of what suffering might be in the future to someone, is actually different from the lived experience of going through the illness. That, someone who doesn't live with a certain disability will look at someone who doesn't say, oh my gosh, there must be so much suffering. And so that idea of personhood, as you yourself go on to live with the disease, that idea of suffering actually changes over time. So that's the disability paradox. And again, MAID assessors do want to alleviate suffering, and that idea of suffering now comes into question later on in their disease. So in the interest of time, potential outcomes of advance requests. So this anticipatory anxiety may be alleviated just by creating the advance request itself. It may never get activated because the qualifying conditions are never met, or an assessor comes by and says, actually, this person doesn't qualify. It doesn't actually convince me that there is intolerable suffering. What if the patient makes gestures that they no longer wish to receive MAID? There's a stranger coming to them that they no longer recognize, and they're wafting them away. That would be a gesture of refusal. Or the family might say, I do not recognize my family member anymore. The person that they were before, the personhood that they received, that they had prior to the advancement of the illness is no longer there. So I can no longer support this idea of medical assistance in dying now. Some of the complexities when it comes to advance requests for MAID in dementia. So again, prior capable wishes are difficult to honor in dementia patients. And we can just look to the Netherlands where, people have these advanced directives. I think 7% of the citizens of Netherlands have advanced directives saying that they want MAID if they ever develop dementia. But only a very, very, very few number of individuals actually receive medical assistance in dying where the advanced directive is enacted. And there's a lot of moral distress around honoring prior capable wishes by everyone involved in the care. And again, kind of mirroring what my previous colleagues was talking about when it comes to severe and persistent mental illness, I echo that when it comes to dementia care, investing in early diagnosis, supporting the family and caregivers better, and having those really difficult serious illness discussions early on in disease management is going to be key. Oftentimes, I see individuals requesting MAID because they haven't had the opportunity to have these serious illness discussions. It's not a desire to die statement. Rather, it's a way for them to express the distress that they're currently in and wanting more information and psychoeducation. So thank you so much. I'm sorry if I'm over time.
Thank you very much, Gina. It's very okay. Thank you for your lecture. And now I would like to introduce our third speaker, this Dr. Kai Ito. Kai is a psychogeriatrician from Tokyo, Japan. Her research addresses the complexities of decision-making in individuals facing intertwined mental, physical, and social health challenges, with a particular focus on ethical considerations in clinical practice. Kai, thank you very much for your participation. We will listen to you.
Thank you. Hello, everyone. Is my slide shared all right? Okay. Is it shared? Okay. Thank you for giving me this opportunity. And my name is Kai Ito. I'm geriatric psychiatrist based in Tokyo, Japan. And let me begin by stating my position on euthanasia, including medical assistance in dying. I do not follow any particular religion, and I do not oppose euthanasia on the basis of the sanctity of life. When I heard that Jean-Luc Godard, one of my favorite film directors, had chosen euthanasia, I felt it was a very fitting decision, very much in line with who he was. But at the same time, I have never found the arguments in favor of euthanasia entirely convincing from a logical standpoint. In particular, I believe that MAID by individuals with impaired decision-making capacity requires extreme caution. In Japan, medical assistance in dying, or MAID, is not currently legal. Where there is growing public interest, A national debate on this issue has yet fully developed. Today, I'd like to explore the topics of MAID, decision-making capacity, and clinical ethics, particularly through the lens of Japanese practice and cultural values. While MAID often draws global attention at the end of life, I believe that in psychiatry, our most profound ethical challenges arise much earlier, in the ongoing care of those living with severe mental health conditions, frailty, and cognitive decline. And every day, we're navigating questions on dignity, autonomy, and vulnerability, not only in how people die, but in how they live. When patients say they fear dying without dignity, often what they fear is not death itself, but prolonged life, heavily medicalized, depersonalized, and without meaning. So, I think we must ask, is the opposite of a bad death necessarily a good death? Or should our ethical responsibility focus on how to support a good life, even amid frailty, cognitive impairment, and uncertainty? For many of our patients, I think this is a more urgent question. And there is an argument that this is a matter of self-determination. However, this act is not something that can be completed by the individual alone. A physician provides assistance, and the value of society which justify the physician's assistance are also involved. Those who support physician-assisted suicide often argue that it does not harm the dignity of those who do not wish to choose it, since it is not applied to them. But can we truly say that the society deems a certain condition as justifying the choice of death? It has no impact on the dignity or value of life for others living with the same condition who do not wish to die. And let me share a case from our hospital. A man with long-standing schizophrenia was diagnosed with metastatic lung cancer. His thinking was disorganized, and he denied having a cancer at first. Yet he asked to see his CT images. And after having some conversation, he engaged thoughtfully with us and initially requested surgery, but later accepted palliative care after discussion. He found a great joy in small daily choices, like selecting his meals. And even with severe mental health condition, his will, his value, and his personhood remained intact. Yet, we often frame capacity in binary terms, competent or incompetent. In reality, for patients with severe mental health condition, capacity is often fluctuating, partial, and situational. Globally, we often see this troubling asymmetry. When patients agree with the medical advice, we affirm their capacity. But when they disagree, we question it. This becomes particularly sharp when we discuss irreversible interventions, maybe including MAID. In clinical ethics, we often associate autonomy with rationality. But even healthy people make emotional, inconsistent decisions every day, and we accept these as valid. For people with mental health conditions, we often expect a level of consistency and logic we do not demand of ourselves. This creates a double standard that risk invalidating genuine expressions of will. In Japan, involuntary psychiatric hospitalization is legally allowed. Physical comorbidities fall into legal gray zone. Family often serves as surrogate decision makers. This reflects a cultural emphasis on interdependence rather than strict individual autonomy. As stated officially in 1995, in Japan, family plays an indispensable role in medical decision-making. Substitute decision-making is often presented as respecting best interests, but proxy decisions are not the same as true self-determination. Our task is to support decision formation, helping patients clarify and express their own value as much as possible. Otherwise, well-intentioned practices may become paternalistic even when justified as protection. This concern resonates globally in May debate. Whose voice truly counts when capacity is impaired? Clinical ethics is not about following guidelines. It is an ongoing process of confronting uncertainty together with patients and families, and balancing dignity, safety, and frailty. It is to listen to the patient remaining agency. As clinicians, our role is not simply to assess consent, but to bear ethical witness to the personhood of those we serve. While May highlight these dilemmas at the end of life, similar tensions exist long before dying. Fluctuating capacity, disagreements between patient and family, systemic assumption limiting patient voice, and ethical discomfort about irreversible decisions. The person remains the subject of their own life even when their cognition is impaired. When clinical ambiguity meets social ambiguity, it's no longer just personal. And the discussion about autonomy becomes one about who gets to matter. And before we decide whether May should be permitted for persons with mental health conditions, including dementia, we must ask whether we have done enough to support their life before considering how they might die. And it asks us to trust the patient's remaining agency even when it is fragile. And it asks us to support the formation of decisions, not just a moment of decision-making. And importantly, it asks us to recognize that many barriers to autonomy are not the patient's fault. They come from the systems we ourselves have built, from laws, institutional protocols, risk avoidance cultures, and well-intentioned overprotection that can end up silencing patient's voice. And yet, uncertainty is not a flaw. It is part of being human. One patient put it simply when we were talking about his end-of-life care, give me a little more time. If I don't know how I feel when I reach to the edge of the death. This patient, he had HIV-associated dementia, and his physical health was deteriorating and his cognitive function declining. His uncertainty did not invalidate his voice. It remained us, clinicians, family, and systems remain humble, flexible, and attentive throughout the process. Ultimately, MAID only magnifies tensions that exist throughout psychiatry. Ethics means respecting free agency, accepting uncertainty, and thinking together with our patient, not only about them. To borrow a phrase, thinking itself is the answer. This is my last slide. So to conclude, this is a summary for ethical reflections I've shared. Autonomy must include fragility. Capacity is often partial, dynamic, and still meaningful. Substitute decisions are not self-determination. Supporting will formation is ethically distinct from replacing it. And as uncertainty is not incapacity. Patients may not be consistent, but neither are healthy individuals. And systemic factors shape choice. Institutional, legal, and cultural structures often limit patient autonomy more than disorder or illness itself. Ethic is not compliance. Clinical ethic is ongoing moral practice, not guideline adherence. May magnifies but does not create these tensions. They're present in all end-of-life and complex care decisions. This brings me to the end of my presentation, and thank you very much for your attention.
Kai, thank you for your passionate lecture and the introducing of some concepts from the another thinking. Thank you very much for our presenters. I think it's a fabulous and reflexive topic, really, with very different opinions. And the debate is open for the audience and for any inquiries and questions. I will start with a personal question. Beside all we considered recently, which is considered the role of a health team that must accomplish with those desires and questions, the legal ones, the ethics ones, the personal ones, the familiar?
Dr. Reich, could you repeat the question, please?
Yeah, regarding that, how we consider the role of the medical, the health team that must take to account of these decisions. I mean, I suppose that there are philosophical, ethical, religious concepts that perhaps may a strong influence in the final decision of a health team in order to respect or not respect the previous decision. Have you experienced or some case situations regarding these ones?
Maybe I can try to answer. Please
Yeah,
try. That is a really good question, right? I've noticed in Canadian healthcare practice, especially in the space of geriatric psychiatry, seniors' mental health, that we're starting to talk more as a system about what matters the most to the patient. And we're trying to install these discussions earlier on in our interactions than anywhere before. And I think this is a direct result of the implementation of medical assistance in dying. That, medical assistance in dying in Canada now is a legislative right, meaning that because it's an exemption from the criminal code, which is a federal jurisdiction, it is now a legal right of a Canadian to request medical assistance in dying. As a result of this, you can think about access to other sort of healthcare where it's not considered much of a legal right to be able to access, let's say, a geriatric psychiatrist or a geriatric psychiatrist that specializes in a certain type of illness. And because of that, there is almost this tension of it's almost easier for someone, let's say in rural Ontario, like I live in, urban Toronto, I love it here, but in rural Ontario, it's easier for them to access medical assistance in dying than to be able to access a very specific specialist in their disease. And that in and of itself creates this tension. And I think we as a medical community as a whole are shifting more towards these serious illness discussions earlier on and trying to almost do more in terms of advanced care planning, even if we ourselves are not palliative care physicians who traditionally used to have these kind of discussions, to the point where I myself, I'm an academic geriatric psychiatrist, and I'm working really hard to implement like a neuropalliative care curriculum into the geriatric psychiatry subspecialty. When we think about psychiatrists, we don't like having serious illness discussions or advanced care planning when it comes to severe and persistent mental illness. We feel uncomfortable, right? We're taking away hope from people. If we were to say, like, what would you like to do if we can't treat your illness, right? We're scared of, triggering another depression. But I would argue that now that MAID is legal in Canada, we have almost an obligation, especially in seniors' mental health, when it comes to, major neurocognitive disorder, to have these discussions around values earlier on, and to be given permission to have these discussions. So one thing is I'm trying to implement it into the University of Toronto subspecialty curriculum, but the other thing that I'm trying to kind of start to do is to explore the possibility of having advanced care planning and serious illness discussions be written into some of our national guidelines when it comes to dementia care. And that, in doing so, it actually gives permission to the psychiatrists to have these discussions earlier on. The other kind of condition that to me is similar to dementia is frailty, right? When it comes to seniors' mental health, there's a lot of individuals that also live with concomitant frailty. And I think when it comes to frailty, it's the syndrome, similar to dementia. It's like a syndrome. It's hard to kind of say, oh, like your electrolyte level is X, Y, Z. It's a syndrome. And when it comes to a certain syndrome, to name that it's frailty, to have these advanced care planning discussions, serious illness discussion, I think is now becoming even more important to hold those now that MAID is a legislative right in Canada.
Thank you, Gina. Thank you very much for your answer.
I think I will read some of the questions. I like to read for the audience and for the speakers the question of Kiran Ravero. It comments that more than 13,000 MAID provisions were reported in Canada in 2022, a 31% increase over 21. And this number climbed to 15,000, and that is 4.7% of all Canadian deaths. So this is before psychiatry med is in place. And he asked, any thoughts about these numbers? Well, this is a question specific to Canada, but maybe I think maybe could be applied and it deserves a reflection about other settings.
I don't want to hog the space.
Oh, sorry.
Go ahead, Carla.
Well, my perception from outside, the numbers are astronomical in my perception. So I'm very surprised. So this is my initial feeling without so much reflection on the topic. So because I like to share these numbers.
Yeah, I think Gina will be in a better position to answer this because it is specifically in Canada. But yeah, I think what is highlighted here is one of the things that people are always scared of with these scenarios is the slippery slope argument, where when you introduce one thing, the next thing, we're just going to kill people because they're old type of scenario. I think the thing from all the literature that I've read is that the thing is, it is that safe regulation should be in place. So I think Gina can speak more about the legislation and so on. But the thing that she mentioned now that is concerning is that you have a legal right to ask for MAID, but you don't have a legal right to ask to see a geriatric psychiatrist. And that is concerning because most of the legislation that I read in the different countries, they do allow, even if people refuse psychiatric care, that they can then still request the assistance to die. And I think we must really rather focus on granting better access to care to support people in better ways, and even other things like I mentioned, the societal support, getting grants for people to assist with getting proper nutrition and safe living circumstances. That will maybe address some of these numbers. The numbers are concerning because I think, yes, it might be that it is just a portion of people that were terminally ill, but I'm sure a lot of that was actually contributed to by the societal factors as well.
Thank you, Carla. Thank you for those thoughts. And, to answer Dr. Rabaru's question about, the numbers, there is this effect that we're seeing, and I'm sure you from the University of Ottawa also seeing the same thing, is that MAID is on the forefront of collective consciousness in Canada. Like, a lot of individuals know about medical assistance in dying now. It's becoming more and more normalized and known about. What is less known is the idea of, and I have kind of touched on this in my previous answer, this idea of early serious illness discussions. They're really hard to have. And I think us as specialists shy away from them quite often because they're uncomfortable, because you feel that you don't have the rapport yet, or you're just doing a one-time consultation, which oftentimes in my case, I admit sometimes I also do one-time consultations, and then you almost hope that we could pass the buck to someone else, a different specialist. This is particularly an issue when it comes to dementia care, because in Canada, as you very well know, as my geriatric psychiatry colleague, is who owns dementia? Which specialty owns dementia? Is it the family physician? Is it the geriatrician? Is it the behavioral neurologist? Is it the geriatric psychiatrist? And so, this onus is on us for us to have these very, very serious, very important discussions earlier on. I also think that what has happened is that MAID has become so popularized in the popular media because it's so provocative. I think it's also reflected in how many people attended today or registered for today's debate. People care more about how they will die. People, in modern society, we care about how we live, and we start to care about how we die. And that sense of feeling like you have some control over what happens in your life in the context of a serious illness, I think that is attractive in a very autonomous society like Canada, right? We don't live in a pluralistic society. We're very, very individualistic. And so that idea of being able to have that, I think that's why when that national survey was implemented in 2020, so many people supported the idea of an advance request for MAID when it comes to an illness like dementia.
I will take a question from the audience, from Nola Green, and I will read literally. The question should be, if I get Alzheimer's and the state and my family warranty that my care needs are met, and I will be treated at all times with dignity, that all the resources what I need will be provided equal to others with healthcare needs, then and only then the question should be asked, would I like MAID if I develop Alzheimer's?
Maybe I can take that one. And I think that brings us back to some of the things that I addressed in my presentation about the societal impact and the systems that we live in and how that contributes. So maybe if we have all our care needs fulfilled, there will not be any of these requests. But it remains to be seen, because we know that we fall short in terms of what we can provide in all the different areas for our patients. Even something as simple as, who is the the physician who is primarily involved, that can lead to a lot of polypharmacy. People have seen different practitioners, and that causes a lot of disjointment between the care that the patient receives. So there's so many things that we can and should do, but that is very difficult to really coordinate care, get better standards of care and access to care. And then if it still remains, and if there's then still such a request, then I think it will be more a case of looking at what's underlying that request. What is the suffering about, and is it the values of the individual, or is it something else that's talking there, undue influence from somewhere?
Thank you, Carla. Thank you very much. There is another question from the audience from Anand Ramakrishnan. It's directed to Kai, but I think we can universalize this one. And is substitute decisions are not self-determination. As culture and family play a great role in making decisions about autonomy, how do we conclude interface of self-determination and autonomy?
Okay. Maybe I'll try to answer. This is a major challenge we are facing in Japan now. As a custom, Japan has long relied on family members to make medical decisions and many of other decisions in our ordinary life too. So, as the structure of the structure of the family has changed, and more people now are unable to obtain surrogate decision making from their families, or like it's appropriate to have surrogate decision making, and they're now forced to make decisions about their own affairs. And with this situation, both medical staff and also patients themselves are discomfort. So it is in Japan, the discussion of self-determination itself has not maturated. And that is one reason that I think it's too early for Japanese people to think about MAID, because we first have to think about what is self-determination and what is autonomy.
And over this one, I think it's very difficult to universalize the concept of autonomy. I suppose that autonomy in Oriental cultures are perhaps a concept different than in Occidental ones. I don't know if I'm right, but what do you think about it?
I think it's different because we do not have a history of being invaded our rights as a nation. So I think it's very different because we are living in Ireland, in Far East. Yes.
Thank you. Thank you.
I think I will read it's quite a long question, but I think it poses some specific problems. Cecilia Tulane says, thank you for your talk, so very interesting. I will be interested in your thoughts regarding palliative sedation for intractable neuropsychiatric symptoms in dementia, especially advanced dementia. Palliative sedation for intractable physical symptoms that result in suffering is common practice in most countries. However, we do not typically palliate neuropsychiatric symptoms in advanced dementia. This, of course, is not an argument to be used against the provision of MAID, but there are always too many suffering, both physical and psychic pain. But at least in Australia, we don't ordinarily palliate neuropsychiatric symptoms with tranquilizers or infusions. Any comments about this?
I actually made a comment in response to Dr. Lane. Some geriatric psychiatrists would consider any sort of management of psychiatric symptoms in dementia. They might consider this palliative care. the concept of palliative care has kind of shifted over the years. Initially, they were, kind of associated with just end-of-life care or imminent end-of-life care. And more palliative care, at least in Canada, has involved itself earlier and earlier in the context of a serious disease, to the point where, when we're thinking about dementia care, dementia is an incurable condition that continues to progress. And early symptom management that involves psychiatrists very often, right? We can all think of cases where we have a 70-year-old man with first onset of anxiety, which ends up being Lewy body dementia, or which ends up being, the harbinger or mild behavioral impairment, as we now call it, of a neurodegenerative illness. And of course, at good faith value, we initially start with treating it as if it's a first episode of anxiety or first episode of depression. But, as a geriatric psychiatrist, you always have those feelers on and look for the dementia or the cognitive decline and the functional decline later on. And then when it does happen to be, an evolving major neurocognitive disorder, at least the way that I see symptom management or psychiatric symptom management is a way to alleviate the symptoms as a result of this neurodegenerative illness, which is pain and symptom management, which in and of itself is palliative care. I agree with you. I agree with the question that we don't typically use these IV infusions similar to palliative sedation at the end of dementia care. And maybe some of my other geriatric colleagues, not just the speakers, can comment on that. What we have seen in sort of the classic dementia patients is that, at the very end of life, they become a little bit more bedbound. They do require, end-of-life care, very similar to some of the other illnesses. But yeah, as I'm thinking about this and as I'm reflecting on the cases that I've been involved with, we don't typically do palliative sedation until the very, very end of life. Yeah, but maybe I'll ask my colleagues if they have any other sort of opinions on that.
I would like to complete the reflection on this matter. I personally like to refresh I think the comment of Kaito during her presentation that we always must support before to consider this kind of alternative. And I like to read a couple of brief comments. First from Marisano. My concern is that so much depends on the physician or other professional perspective. Legislation to protect the professional who acts in good faith may be very important if we want professionals to do this very challenging role. Perhaps we need advocacy for the provider. And the comment from Kiran Roberto, we need better access to good care and support before we offer med. So maybe this complements the reflections. I wonder if somebody like to make additional comments. I personally feel in my environment in Spain, my mind tends to be a bit reluctant in these conditions to state, to offer this possibility, because just the fact to make this statement is, in my opinion, maybe a push and make some pressure to this very weak population and their families. So how complement this? And because of these reflections, I think it is important. I personally like to emphasize that we must offer good care before to consider this. And nowadays it's quite difficult to be sure. So I would like to make comments on experience. I'm sure this changed a lot from different regions of the world, and maybe it deserves comments from different members of the audience.
Raimundo, is it okay to speak?
I think so.
Right. Okay. Hi, Raimundo. It is so nice to see you after 10 years. So it's great. This is Krish from Royal College of Psychiatrists, UK.
Nice to listen to it again.
Yeah, thank you. That's one thing. Second, I mean, what I want to talk to you about is the topic, the point you just made is that when UK, the Mental Capacity Act very clearly gave provision to do the best interest assessment by the family, by the clinician, by the professional, joined together to have a decision whether, for example, people have palliative care were unable to give consent for intravenous pain medications or whatever. But that is then decided by the family and especially the family who know the likes and dislikes of the person and how that person would have liked to suffer in case he had the full capacity to make that decision at the time. So that kind of a best interest assessment gives a very good framework in which we could make a decision whether what we are doing for the person. I'm not talking about the medical assistance dying, which is entirely the onus of decision making is much higher when compared to giving a palliative intravenous medication. So that kind of framework would have been very useful in making this kind of day-to-day decisions. Thank you.
Thank you.
Debate implies controversies, and I would like to read a message from Victor Ilia from Mexico. Literally, he says, I consider that any law that favors MAID a crime. Geriatricians can provide care and quality of life to terminally ill patients without suffering and with dignity until their death. Fortunately, in Mexico, MAID doesn't yet exist, and we only have palliative care. I don't know if any of the speakers or the audience have some opinions regarding this one. Any of the audience?
Yeah, I raised my hand, but I don't think you can see my hands. No, not a problem. So I am from the Netherlands. I performed euthanasia on a patient with dementia 2 days ago. So I'm not sure how you will look at me right now. I think that within the scope of the disease and with the existential dilemmas and especially the suffering that comes with the trajectory of the disease, I'm very reluctant to perform euthanasia in any patients. And I'm even more reluctant to perform euthanasia in a patient with dementia. So I'm convinced and I'm hoping that it will never become regular practice or an easy way, because it is a very big experience for all parties involved. But I am very happy that this option exists for those specific patients that do need something else than we can provide with palliative care. So in extreme situations, in a very small number of patients, I believe that euthanasia and MAID can help people with respect to all legal criteria, with respect of the doctor's own opinions and their own moral beliefs. So a lot of barriers, but denying that MAID can be an asset to your healthcare, I think is not the right way to go.
May I make a comment? I would like personally thank you both, the person who wrote the sentence in the chat, and personally also particularly to you, because you are replying in person, showing your face, and with all your respect to the audience. I think this is the kind of debate Eddie and myself like to get a debate full of respect and open to all the opinions of the attendants. So thank you both for being so frank in this debate.
Leah, we are looking your hand raised. Please, do you have any comments or questions?
Can you hear me?
Yeah.
Yes.
Yes.
Okay. Good morning to everybody. I have been hearing all the presentations. I congratulate the speakers. They were really very, very good. I was very impressed. And I think it is a very important subject that we have now. This is something we face every day in every day's work. We, as geriatricians, probably more than psychogeriatricians only, and I think that, excuse me, para un minuto la aspiradora. I'm sorry. This is domestic problems. I'm really sorry. I'm sorry. But anyway, I want to tell you that in Argentina, we do have a law on palliative care, and it is it's working. Well, I'm sorry. I'm sorry.
We'll wait for you, no problem.
Para la aspiradora un minuto. Para la aspiradora. Para. I'm really very sorry. I apologize. I didn't realize this was going to happen. Anyway, as I said, we face this nearly every day in our practice, and even if we don't have a law or we don't have anything formal on medical assistance on dying, this is happening in Argentina. As I said, it's not formal, but it is informal. And I think that for us, medical profession, it is important to take into account patients' desire. I personally try to get to know what they would like to have if they are very ill or if they're going to die. I would like to know it in advance. It's something that I talk with my patients along the time that we are together. And even
We cannot hear you, Leah.
Leah, you're fixed. In the meanwhile, I would like to read another comment from the audience. Rosemary Kelleher says, I wish palliative care did meet all situations, but that is not what I have witnessed. Not fair to impose practitioners' moral position on all patients and families.
So, and I can just speak to the Canadian context. In Canada, a practitioner can conscientiously object to participate in anything that has to do with medical assistance in dying, much like some of the other medical procedures that are legal in Canada that are also met with conscientious objections quite often, like abortion, late-term abortion, and whatnot. And oftentimes, obviously the physicians have their own moral upbringings, their own moral compass, religious affiliations, which direct their values. In Canada, the obligation oftentimes is to perform an effective referral. Now, what constitutes as an effective referral is oftentimes different in practice. And so there have oftentimes been cases where there's been, how shall I put this, a slight stalling of effective referrals. Or a willful dragging of the heel. Or an effective referral can look like passing a case on to a colleague, that would consider be a gold standard effective referral, but it can also mean saying to the patient that you yourself have to seek out another provider. And that sort of has been the route that people have taken who, conscientiously object for religious reasons.
Thank you, Gina. I would like to rescue for the three brilliant presentations we had from the speakers the word autonomy, the concept of autonomy. Who says for us what autonomy is? I mean, how to establish what autonomy is besides the definition of the patient itself?
So I'm going to take a stab at this, but it is a very difficult question. It is very complex. So I think, in a culture like in South Africa, where there is still a lot more focus on the community and the family system, that makes the autonomy of the individual less important in certain cases where, the head of the household or in the community will make decisions that we sometimes have difficulty with, because as in most of the cases that we discussed today, there is really a patient, person-centered focus in the care that we provide. So in the end, we have to bring it back to the individual. But some of the arguments that I read about using autonomy for and against the arguments for MAID, the one argument was about, but if you then take the autonomy away by ending the life of the person, can that really be seen as an autonomous decision? Because, then you end their life, basically. But I think in the end, it is really that balance of looking at the decision-making capacity. We know all those things that you have to look if the patient really, truly understands, if they have sufficient information to make the decision, if they are consistent with the decision, so it can't be just a one-time thing. You have to check that it is really there and it stays the same over time, because people change their minds. And then, we have to really balance all those things together with the risk of the procedure that will have to be implemented. But so it is very complex. It's not very easy to answer.
Absolutely. Very difficult topic. We are almost closing, and I would like to read two comments. Marieke de Boer from the Netherlands says that in the Netherlands, euthanasia made is not a right from the patient, nor is it an obligation for the physician to perform. Also, substitute decision-making is never an option in euthanasia or MAID. And Rosemary agree with or add to Marieke, there is no way where euthanasia is considered without explicit request of the patient. Patients do not have to state that they are against euthanasia, as euthanasia will never be offered by a physician, but can be requested by a patient. Any comment regarding these sentences or opinions? I have another personal question. What happens when, for instance, a patient says clearly his wishes and his volunteer regarding the counter opinion of the family, for instance? How much weight the family opinion and the patient personal opinion?
Well, I can answer only for the Netherlands, and it's never as black and white as I'm going to suggest it is. But in the end, ultimately, the opinion of the family does not matter. Of course it does. Of course you take it into consideration, but in the end, the patient decides. So if the patient wants euthanasia and is meeting all legal requirements, he or she can request euthanasia, with or without the family agreeing. On the other hand, a family can never request euthanasia for a patient. That is just impossible.
Thank you, Rosemary. Thank you. Other opinions regarding this topic? I mean, family not agreement without opposing to the patient wishes?
There's actually a study that was done in Canada surveying MAID providers as to whether or not if there was family opposition after an advance request has been drafted up, but the family does not support this. There's a huge decline on MAID providers willing to carry it out if family support is withdrawn.
Thank you, Gina. Raimundo, we must almost to close this passionate debate. Really, I think it's one of the best debates we have regarding the quality of the speakers and the polemic of the opinions. Your comments in order to ending?
Yes, I'm very grateful to the three speakers. I'm very grateful to the audience always, but I think particularly in this time it has been very productive and providing quite complete reflections. Several of the comments emphasize the need to continue analyzing this complex topic. So, Eddie, I think we have to pass this request to IPA meeting organizers because I think this topic deserves a more profound reflection. Thank you again to all for this wonderful experience that I enjoy a lot. Thank you so much.
Thank you very much, mainly for our speakers. Really congrats for your talks. Thank you for the audience to attend this meeting. And I agree with Raimundo that it will need certainly a second part and discussion in IPA meetings in the future. Thank you very much, people, again, and we hope to see you in Kanazawa.
See you in Kanazawa.
Thank you.
Thank you.
Bye-bye.